Good morning. Today I'm going to be talking about surgical management of articular defects of the knee. This is based on an educational course lecture that was published in JBJS last year by Gamal et al. So a bit of background. Cartilage, as we know, is made up of type 2 collagen fibres and proteoglycans and water. The chondrocytes within cartilage synthesize the collagen and the proteoglycans. Very good. But cartilage has a relatively poor healing capacity. It is avascular, receiving its nutrition from the synovial fluid. In an adult, has no pluripotent cells for healing to occur, and therefore has a limited synthetic ability in an adult. There is some ability for small peripheral lesions to heal, but otherwise cartilage is very difficult to heal. The clinical features of cartilage defects in the knee are a large proportion of intra-articular knee cartilage defects are asymptomatic. Other symptoms include pain, clicking, locking and swelling. And the pain is related to which part of the knee the disease is in. So for patellofemoral pain, they'll have mechanical pain when walking upstairs or crouching. Examination may find no positive findings, but there may be an effusion, crepitus or tenderness. At this stage, the authors of the article stress the importance of looking for ligamentous instability, malalignment of the knee, or for any abnormal tracking of the patella. Imaging choices for diagnosing and working up intra-articular cartilage defects include plain film, which they say to do your standard AP lateral notch and patella skyline views, but also to include full-length hip to ankle films on AP to look at the mechanical access of the knee. MRI is becoming more and more valuable in terms of diagnosing these defects. There's newer cartilage-specific protocols that can be used on MRI, which give quite good pictures. CT I've put up there, but has quite a limited role in looking at cartilage defects in the knee. The natural history of these defects is relatively unknown because such a large proportion are asymptomatic and only picked up at arthroscopy in an asymptomatic knee that's symptomatic for another reason. So it can be difficult to educate your patients in terms of what's going to happen if we do nothing and what's going to happen if we treat. Cartilage defects can be classified according to the Outerbridge classification that we commonly use at knee arthroscopy, with grade 0 being normal cartilage, grade 1 being cartilage with softening and swelling, grade 2 being partial thickness with defects with fissures that don't exceed 1.5 centimetres or that don't reach subchondral bone. Grade 3 defects have fissuring to the subchondral bone and or greater than 1 centimetres of cartilage is involved. Grade 4 lesions have exposed subchondral bone. The treatment options this article talks about for managing cartilage defects in the knee, they advocated conservative treatment for all patients for at least 3 to 6 months, and especially in patients where they think who have got a contraindication to having a repair done. And this group they included smokers, obese people with BMIs of greater than 30 to 35, all patients with inflammatory arthritis, knee malalignment or a meniscal disease, ligamentous instability and significant degenerative changes. They all earmarked as contraindications for repair of articular cartilage. The surgical management of articular cartilage defects include debridement of the edges of the defect, microfracture, osteochondral autograft transfer, autologous chondrocyte implantation, And although the authors of this American article didn't mention it, we obviously use MACI, so matrix-induced autologous chondrocyte implantation. And the final option also being osteochondral allograft transplantation. So I'm just going to go through those options and talk about that a little bit more. So microfracture is often the first line treatment for full thickness cartilage defects. In this treatment, a curette is used to create a vertical stable edge of the lesion and debride the defect, but not beyond the subchondral plate. Then multiple holes are made with an awl or a small drill, about 3 to 4 millimetres apart, until fat globules are seen coming out of the drill holes. And prior to finishing the arthroscopy, the tourniquet should be let down to ensure that blood is coming out of those small little drill holes. The theory behind this is that the blood forms a superclot of pluripotent marrow cells, which are quite good at producing fibrocartilage. The aim of this treatment is not a return to true articular surface, but rather a hybrid fibrocartilage that will help relieve symptoms. Post-operatively, the authors recommend quite conservative management with 6 to 8 weeks of non-weight bearing and also CPM during that time, which they haven't specified how many hours a day or for how long. Microfracture has been studied in a JBJS article in 2007, which compared it to autologous chondrocyte implantation and showed very similar results between both groups, though small lesions in the study did a lot better. So osteochondral autograft transplant the theory behind this is using the patient's own bone to implant the defect. It's an arthroscopic procedure or mini open that may require, if it's arthroscopic, it may require multiple accessory portals to get perpendicular access to both the harvest site and also the site of the defect. When looking at where to harvest some healthy cartilage for using these plugs to fill the cartilage defect, they recommend using the trochlear notch or the periphery of the femoral trochlea. The most important reason for doing this is that these are non-weight bearing areas of the knee. The donor site is then filled with these plugs of bone in a mosaic type pattern to try and achieve 60 to 80% coverage of the defect. Post-op, the authors recommend touch weight bearing for 4 to 8 weeks and to consider an MRI, so any lesions that are on both surfaces of the femur and tibia, or of the patella and femur, because these kissing lesions tend to do a lot worse than a unipolar lesion. The harvest site for taking a biopsy is the superolateral aspect of the intercondylar notch. At the time of biopsy, about 200,000 cells are harvested, which are then cultured to 48 million approximately in 6 weeks before implantation. So at implantation, an arthrotomy is performed, and the margins of the defect are sharply defined with a curette or knife, and a patch of the periosteum from the tibia is used, or a collagen membrane they report in the study can also be used as an off-the-shelf patch to cover over the defect, which is then sewn in place, leaving one open edge, and the chondrocytes are injected into the space. So there's a picture of this technique being performed. So this is a femoral condyle with a patch of periosteum sewn in with nylon suture and some fibrin glue, and using an angiocath, they're inserting the chondrocytes under the lesion. To close this repair, they recommend putting another couple of sutures in and then more fibrin glue. Recovery from this procedure is quite slow, as initially the graft is quite soft and not integrated to the underlying cartilage and bone. The authors recommend 6 weeks weight bearing with up to 6 to 8 hours of CPM daily. They also say no running for 12 to 18 months and no ball sports for at least 18 months, which the Americans call any sports with cutting, so when you're making sharp direction changes. This technique has been studied as well in a randomised control trial compared to Macy, which showed actually better results than the Macy in this one study. A Cochrane review in 2006, which shows the paucity of good controlled trials in orthopedics, comparing mosaic-oplasty and microfracture to ACI, showed no evidence of significant difference between the three interventions, but obviously said there's a lot more scope for matrix-induced chondrocyte implantation, or MACI, is similar to ACI, but relies on implantation of living viable cells as a substance, similar to that of hyaline cartilage. The cells are grown on a membrane and don't require the same periosteal cover. It's still a two-stage procedure. A harvest arthroscopy followed by culture and implantations approximately 6 weeks later. At implantation, an arthrotomy again is required, and it's a very similar process where curette and knife are used to debride the defect and ensure a stable margin. And then the defect is sized and the insertion of a MACI graft is used using fibrin glue for fixation. Post-operatively, the authors recommended, well, the authors didn't actually mention MACI at all, so looking at other literature, it's commonly recommended to use non-weight bearing for 8 weeks and no sport for at least 6 months, but often. This was studied in an article in 2007 with a 5-year clinical and MRI follow-up, which showed 90% good or excellent filling defects of chondral surfaces on MRI, and 86% were able to do their normal activities of daily living